So coming to you again this evening, tonight we'll be talking about understanding health disparities part two. So we did part one last time. This time we'll be focusing on clinical trial diversity and prevention through the lens of health equity. And let me jump to my first slide here. So my next slide just really speaks to my business, which is Relane Consulting. And I offer you the opportunity to connect with me on any of my core services, which include leadership coaching, professional development, leadership retreats, business strategy and planning, keynote speaking and moderation, and of course, I offer the Bold Bet podcast as an offering through Relane as well. And Lisa did a great introduction for me. I'll just shorten it up by sharing my personal experience and connection with clinical trials. I have, and I'm currently a clinical trial participant, have been before. My father was a clinical trial participant prior to him passing away, unrelated to the clinical trial, but he was on a clinical trial. And so I've had the opportunity to directly experience clinical trials from a personal position and from a caretaker position. And so that's part of the expertise I bring to you today also is that direct experience as a clinical trial participant, having offered myself up in the way of learning more. And so I'll start where I started last time. In part one, we really talked about health disparities and why they exist. Tonight, again, I want to connect on the clinical trial perspective because equity in research really is equity in care. And so the National Institute on Minority Health and Disparity defined disparities as preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health experienced by socially disadvantaged populations. And health equity, to me, really means that every person has an opportunity to be as healthy as possible. If you would, drop one word in the chat that comes to your mind when you hear health disparity. I'm going to see if I can open the chat and take a look at it myself from here. If you can think of one word, preventable, awesome, bias, non-referral, I like that, denial, unfair, location, disadvantaged. All very fair assessments, unequal, unequal. All very fair assessments, very fair words to choose when you think about health disparities. They are all of those things. They are unequal, they are unfair, they are disadvantaged, they are almost targeted, but they are absolutely preventable. And so that brings me to my next slide, if I can get there. So I want to ground us a little bit in clinical trials because clinical trials help us to meet the equity as it relates to disparities in healthcare in a certain way because they help to deliver our drugs, the drugs that we'll be receiving as participants of society. If you've ever taken a Tylenol, if you've ever taken aspirin, if you've ever taken a prescription drug or an over-the-counter drug, you are essentially participating in the back end of a clinical trial. Those drugs have gone through clinical trial. What you see on the screen here is all the phases of clinical trial. So you have discovery and preclinical, you have phase 1, phase 2, phase 3, and those all go to support the final FDA approval of any drug that is going to be prescribed or received in the United States of America and across the globe. There are different clinical trial processes or FDA approvals or regulatory processes that occur outside of the U.S., but in the U.S., the FDA is the final approval entity. And so clinical trials, whether they're medical or whether they're testing a medical product or a strategy, they're testing the safety, efficacy, and appropriateness of that drug, and they're testing it and whether or not it's appropriate in different groups of people as well. The FDA requires that evidence. They require the safety, the effectiveness, the side effects, and who it works on. And so, without diversity in these trials, we don't know if the medicine works for everyone or just for some people. And so, that's why clinical trial diversity is important. Please feel free to stop me along the way, too, if there are questions. I do want to call out this point. Why is representation in clinical trials so important and why that matters? Black people make up about 13% of the US population, but often less than 5% of participants in many new cancer drug trials. And this is from the FDA drug snapshots. I would like to know, if you are not in the data, how can the data protect you? If you're not included, how can it protect you? And so that lack of representation can mean sometimes higher risk of side effects or ineffective treatments for the populations with the highest disease burdens, which is a little scary. So I'll give the example. If the majority of patients in a particular disease state, we know that African American patients often, or I should say, those who have multiple myeloma are often African American patients. There's a higher incidence of multiple myeloma with African American patients. If the clinical trials that moved the drugs forward that are meant to treat multiple myeloma don't include African American patients, how can we ensure that it's effective? How can we ensure that it's safe in those patients who are going to receive the drug more likely than others? And so that's why representation in clinical trials are important. And I see a hand up.
Yes, thank you. I was actually considering sharing that my husband's primary care provider, moved from the practice to maybe a concierge type different practice. And my husband enrolled with a new provider. He saw the provider for the first time, and the provider said, "Why are you taking thus and such?" And he shared why the previous provider had prescribed it for him and why he was taking it. And he told him, "Well, I'm going to take you off this because really the people in the clinical trials were not African American, men." So that my husband experienced that about a year and a half ago. And
Oh,
and
wow.
they took him off of it, and everything has continued to be okay.
Thank you for sharing that. Thank you for sharing that. I think it's important and incumbent upon us to ensure that we have providers that look out for us in that way, but also to educate ourselves and check into those clinical trials. Ask those questions of your providers when they are prescribing those medications for you. Ask how effective it was in the African American population during the trial phase. And it would be interesting to hear whether or not there were any African American patients represented in the trial at all. That's important to know. That's an important safety measure. So thank you for sharing that, Deborah. Thank you. And so, why does that representation strengthen science? I think we just heard a great example. Clinical research is really built on two pillars: scientific rigor and generalizability. Rigor means that the data are reliable and reproducible. It can happen over and over again. You can expect the same result generally over and over again. Generalizability means that the findings apply to people who will actually use the treatment. So it applies to patients in the US, for example, or it applies to African American patients, or it applies to those patients who will expect to get the treatment. National Institute of Health and the FDA expect that trials produce data that reflect the intended users. When we exclude whole communities, we weaken the science. So inclusive research isn't just about optics. It's about data, quality, and safety. And so just remembering those tenets as we continue forward in this conversation: generalizability, scientific rigor, that's why these things are important. I do want to sort of also just talk about how health disparities and research gaps are connected. And I'm going to bring that forward as we move into the next slide here. Let's talk about how these protections have evolved over time and why trust is really complicated. And so I'd like us to take a step back into history because I don't believe in ignoring the fact that where we have been, we have to acknowledge where we've been in order to get to where we're going. And so we recognize that very real atrocities have happened in the clinical research space. We have the Tuskegee syphilis study where treatment was intentionally withheld from Black men for decades, recognizing that even in the midst of a diagnosis, even recognizing that there was a diagnosis, there was a treatment available and it was withheld for scientific reasons. And it was well known. We have Henrietta Lacks, where cells were taken without consent, used in countless studies, and never acknowledged. That is a lack of transparency. And so we recognize that mistrust is not imaginary, it has been earned historically. So let's talk about the history. This is a quick timeline of some of the major clinical trial milestones over time. Our very first recorded clinical trial, 526 BCE, before Christ. 526 BCE. That very first clinical trial, and I invite you to explore some of these a little deeper. We won't have time to go into them today, but I invite you to explore them a little deeper. That very first clinical trial looked at health outcomes of meat only versus a vegetarian diet. Yeah, you actually see references to it in the Bible. 1025, an Iranian philosopher and physician, lays out rules for drug testing in his book, The Canon of Medicine. So we are very early. 1537, French surgeon Paris conducted an accidental trial by necessity on the battlefield when they ran out of cautery oil. 1747, James Lind. I'm sure if you're in public health, you've probably, or in clinical trials or in science, you probably heard of James Lind. He conducted a controlled clinical trial. 1747, okay? That was 1747. Then we move into 1863, which I think I cut off of this slide by accident. And then we jump all the way down to 1943, where you have the UK's Medical Research Council conducting the first ever double-blinded trial. And double blind in clinical trial means that neither the participant nor the physician know what drug or treatment the patient is getting. It could be a placebo, or it could be an active drug, or it could be a newer drug and an older drug, even if they're both active. 1947, we have the Nuremberg Code, and that is the first international guidance on patient ethics during medical research. So not until 1947. We've been doing clinical trials since before Christ. And then in 1947, we finally have some code coming along. 1962, we have amendments that guaranteed informed consent for all patients. And between 1974 and 1979, you have the U.S. National Research Act and the Belmont Report, which ensured more protections. And in 1996, we actually have global clinical practice, or good clinical practice becomes the gold standard for all clinical trials across the globe. That is a global initiative, a global expectation that scientists maintain as they conduct clinical trials. And so just a quick history there. I want to call out some of how some of those research protections really evolved over time. Um, every modern research protection exists because of some sort of failure that came before it. The Nuremberg Code established voluntary consent after World War II atrocities. The Declaration of Helsinki in 1964 introduced independent ethical reviews. In the US, the Tuskegee study and the use of the Henrietta Lacks cells without consent led to the National Research Act. That was 1974. And then you see the Belmont Report coming about in 1979, which gave us the principles of respect, beneficence, and justice. And so we adhere to those. If you know anything about clinical research, or if you've been through GCP training, you understand respect, beneficence, and justice, ensuring to respect the patients, ensuring that they receive the best treatment as much as possible, and ensuring that they receive justice. and that they have the opportunity to experience the trial in the way that they want to experience it. If they want to come out of the trial, they want to be in the trial, everybody has the opportunity to volunteer at their will. And so today's IRBs review every single study, and participants must give their informed consent as well. These rules were won through accountability and advocacy. And so I just want to lay down the foundation where we've been, but look at where we are now. We have come away. We are moving forward. We have people watching these clinical trials from the beginning of the trial all the way through, and not just the physician that's treating the patient. A pharmaceutical company is required to monitor those clinical trials. Pharmaceutical companies must provide what they call a monitor to go out and assess those trials on a regular basis to ensure the safety and the effectiveness of that trial. And so there are protections there now. We have been where we have been, but we are now moving forward. So let me just go to my next slide here and just want to talk about some of the barriers to participation today and how I see hand up again, Deborah.
My apologies. I couldn't figure out how to raise my hand quickly. Henrietta Lackey, a statue or historic marker has been erected down near the center in the square in Roanoke, Virginia. So recently.
Awesome.
Hmm.
Oh, that's awesome
And,
to hear.
and I am a Tuskegee grad, so I know the history of the the syphilis.
Yes, thank you. Thank you for sharing that, Deborah. Anybody else have anything to share? I would love to hear your experiences about anything that I've discussed so far. Anybody have a personal experience they want to share or knowledge? I love to hear that Henrietta Lacks has a statue erected now. And then you said Lackey. Is that a correction? Should it be Lackey and
No, I
not Lackey?
apologize.
Oh,
I added a
okay. Okay. I want to make sure I'm saying it right.
Excuse me. I just wanted to say if anyone has not read up on the story of Henrietta Lacks, it is so worth reading. It was just amazing to me what happened to her, and how that turned out in terms of them not respecting her, and just, oh my gosh, it was horrible. So please, if you haven't read her story, please read it.
Yep, it was integral in getting some of our current processes established in clinical research. So yeah, Lisa, I see you're off mute.
Yeah, I wanted to ask the group of the ones online, for yourself first, have you ever been asked to participate in a clinical trial? And raise your hand or put yes or no in the chat. Either way, I'm curious. And then the second part to that is, do you know of someone who's been in a clinical trial? Mm-hmm.
Uh, Lisa, I can't figure out how to raise my hand.
That's okay, Gwen. That's okay.
But
That's okay.
I was going to say I've actually participated in some clinical trials that needed a control population.
Okay.
And I found that really interesting because some of the testing, for me personally, I wanted to know what those results were. So it gave me an opportunity to have some testing that I would didn't have to go through my primary care doctor to have. Um, so it there are many different types of clinical trials, and the speaker tonight, Alana, has done a great job of emphasizing some of the safety nets that have been put into place now to
Mhm.
prevent some of the issues that have occurred in the past.
Yeah. Thank you, Gwen, and thank you for clarifying how you participated as well. I saw Walter, you put no, but your sister has, and Deborah, you put yes and yes, but I'm still, it's still amazing to me that the no is you haven't been offered or asked, and maybe you're not in a position where you would need a clinical trial or be offered one for whatever reason. But by the time this is over, the last question is going to be, would you be willing to participate and would you be willing to ask about a clinical trial? And Belinda, your hand is up.
Yeah, and you know, it's unfortunate, but the reality of it is by the time we get to a certain age category, that's when we start learning about um, participating in clinical studies and even learning about them. Because for the majority of us, below a certain age category, we were fairly healthy. And so it's not something that our doctors would talk to us about. And even after we reach go over a certain age, they still don't talk about it. So lack of knowledge is not necessarily on our part, it's just unaware that it did not exist.
Yeah. And I think that's one of the things that I hope to bring to the table today is the awareness that there is an opportunity for us to go out and find our own clinical trials too. You absolutely can depend on your physician to help identify those clinical trials. The clinical trial that I'm on, my physician, I don't even know that he knows that I'm on it right now, right? It is not a therapeutic trial. And so a therapeutic trial is a trial where you receive medication that you intend to receive some potentially benefit from, right? I am on an observational trial. I'm on an observational Alzheimer's trial that is observing patients of diverse backgrounds for changes in their brain. I get an MRI and a PET scan once a year to see what my brain functionality is like over time. And this clinical trial goes on for until they no longer have the funding to keep that clinical trial going. But I found that trial myself. My doctor didn't tell me about that trial. I actually saw an advertisement for it and called in about it to find out more and signed up. So sometimes you know we can identify those trials on our own too. So just keep that in mind. They don't always have to be therapeutic, meaning that they don't always have to include medication. Some of them can be observational, and you would still be helping to advance science by doing so. And so health equity and that research diversity really are two sides of the same coin. The same factors that limit access to care also limit access to research. Just like you said, those same things that are impacting us in the care realm are impacting us in the research realm. And if patients who bear the greatest burden of disease aren't represented in the science, the solutions won't fit our reality. So we sometimes have to take extra measures. We absolutely should be able to depend on our physicians, but sometimes we have to take those extra measures ourselves to identify those trials. And I recognize that trust is earned. And for so many of us and many of our communities and many communities like us, it has been broken. It isn't imaginary, it's a rational response to history. Our job now really is to match the science with transparency and respect. And so I want to talk a little bit on this slide just about some of the barriers to participation today. Even with protections, barriers still persist, right? There is the mistrust and fear of being exploited. There is the potential of lost wages and the potential of time burden. I know the clinical trial that I currently participate in, I am lucky enough, blessed enough to work from home. And so I can take pick my laptop up, and wherever my laptop is, I can work from there. Everyone is not afforded that ability to do so. And so if you are in a clinical trial or if someone is in a clinical trial and they don't have the ability to take time off from work, then the lost wages, of course, is something that we think about. As pharmaceutical companies build clinical trials, more and more they're getting to the point where they understand those burdens and they're building in protections for patients. There are financial barriers that are impacting patients negatively to participate in trials, but some of these trials are now providing reimbursement for some of those lost wages. Some of them are actually giving stipends ahead of time. So the difference between a stipend and a reimbursement is stipend is just the money that they give you for participating. On the clinical trial I'm on, I just get cash for going to certain visits. However, if I needed to take the bus to my clinical trial, I could pay for it up front and then they could reimburse me for the money that I may have spent too. So there's a difference between stipend and reimbursement, but those are things that we're doing in the clinical trial space to help support lost wages. Time burden, reducing the time that you're spending in the clinic to participate in a clinical trial. Also, maybe even providing opportunities for decentralized clinical trial elements. And those things are like a virtual call as opposed to having to be in the clinic having that conversation with the doctor. Lack of childcare and transportation, narrow eligibility criteria, and complex language. Clinical trial informed consents are meant to be written at a ninth grade level so that they are at the level of, I'm sorry, not ninth grade, sixth grade level, the low enough in complexity such that anyone should be able to understand it. Sometimes there's still complexities included, right? And so we still have to understand there is a level of knowledge that we may not be aware of in any case, right? Like I cannot say that I'm the most well versed when it comes to technological things. I don't know everything in that space. I know a lot in this space. Me and you may be opposite. You may be technologically advanced where I may be technologically ignorant. And so we have those complex languages. We have the expectation of reviewing those trials and making sure that they are called literate, health literate. And so we try to do those things to remove those barriers. And narrowing eligibility criteria is challenging. Those eligibility criteria are built into trials for safety reasons, but they can become exclusive. And so it is incumbent upon clinical trialists to look at those eligibility criteria and make sure that they're not overly exclusive. And so that challenge continues to be there. We also have very few Black investigators and staff at clinical trial sites. And we know that people like to be sometimes in places where they can connect culturally and see a face that may be familiar or understand their background. And so those are things that continue to progress over time too, is building of Black investigators or Black physicians that do clinical trials. And these aren't necessarily individual failures. These really are structural design flaws that we continue to work on and continue to try to fix. I want to talk a little bit about maternal health as a case study to this. So the CDC reports that in 2023, the maternal mortality rate was 50.3 deaths per 100,000 for Black women and 14.5 for white women. That gap persists regardless of income or education. So in this particular case, we're not talking about zip code. We are truly talking about race and ethnicity. Peer-reviewed studies show that most pregnancy-related deaths are preventable. Again, we're back to health disparities being preventable. And so when trials and research don't reflect our bodies or experiences, the solutions miss us too. So keep that in mind as we are not participating. We impact maternal mortality. We impact disease, or we impact disease and health outcomes as well. I want to talk a little bit about how policy is trying to help some of this. So policy change drives system change. In 1985, we had the Heckler Report, which called racial health disparities a national crisis. That, if anybody can help me calculate, I was born in 1979. I'm 46. That's a long time ago to sit on disparities and recognize them as a national crisis. And then not until 1993, we see the Revitalization Act, which required inclusion of women and minorities in NIH-funded research. You didn't see that come along until 1993. I was 14. I'm 46. And in 1993, we finally see where we are requiring that women and underrepresented populations are included. In 2022, you saw the FDA actually create an expectation called a diversity action plan, which required industry to plan for representative enrollment. I just want to acknowledge that each step moves us closer from acknowledgement to accountability. They are small steps along the way. It seems like sometimes it takes years to make those steps, but there are steps along the way. And as those of us who work in the field pay attention, we pay attention at all times. We overcome, we don't have to call it diversity or diverse enrollment to acknowledge it. We acknowledge it and we make sure that it is adhered to at all times. So you have those of us who work in the field too, working behind the scenes, making sure that we pay attention to these things. And so what does inclusive research look like? Real solutions may look something like this, maybe partnering with community leaders, doing events like this, having these conversations, making sure that there is awareness of clinical research. I like to think about clinical research. If anybody knows anything about marketing, you know about the funnel, the marketing funnel. The top of that funnel is awareness. This right here is awareness about clinical trials. This is a marketing, for all intents and purposes, a marketing event for clinical trials, making sure that the awareness is there about clinical trials. And we do that and we partner with trusted community leaders and we make sure that they are aware so that they can continue to speak the word down and share until we get to a patient that maybe needs a clinical trial and can participate. Providing that transportation or childcare, providing flexible hours, using those plain language summaries like I talked about, making sure that we hire diverse staff. One of the events I went to this weekend was the Black Women in Clinical Research Conference. It was in Atlanta, Georgia. It's a fairly new organization. We haven't seen an organization like that in our industry. They were founded in 2019, took all the way to 2019 to get us a Black Women in Clinical Research organization where we focus through that organization on hiring diverse staff into the clinical research field, ensuring that they are trained, ensuring that they bring their cultural humility to the table when seeing patients, when conducting trials. And then someone mentioned this, sharing the results back into the community. That's transparency, making sure that people know what the outcome of these trials are. And these really shouldn't just be extras for us. These are practices for equity. So if you had to call out one, what do you think would be the most, what would build the most trust where you live? Is it access, language, representation in trials, or in staff, or something else? What would help to build that trust in clinical trial? If you had to call it out, what do you think?
Research sites near me having access, making it a part of the everyday community, something that is ongoing and a part of what, that's what I would call out.
Mm-hmm. Availability. Mm-hmm.
Yep.
Anyone else? Anyone else? Can you think of what might make it better for you? What might make a clinical trial something that you would consider?
I think representation in staff, having someone that you feel comfortable talking with, that you develop a level of trust and feeling as if they're committed to giving you information.
Mm-hmm. That cultural recognition.
Yes.
I think we can all recognize that. That's like walking in the room and you're the only person of your race or ethnicity, right? It always is I think we all manage, right? 'Cause we don't have a choice. But the first thing you do is kind of look around like, I see a familiar something. And when there's no familiar anything, sometimes that's a little like, okay, I'm the only one here.
No, you feel intimidated when you walk into a room where there's no one that you feel that you can relate to.
Mm-hmm.
So it's easy to feel intimidated, and it takes a while before you feel comfortable with the people that you're interacting with. So I do think representation is a big issue.
Awesome. Thank you for that. Anyone else want to share? Okay. Let me go to the next slide here.
I think representation in our race, I think Walter put that in the chat.
Mm.
Same thing, unless that's what you were calling out, Alana, my bad.
Oh, I didn't see it. Nope, I didn't see
Okay,
it.
okay.
Okay. Yep. I think that awesome. Okay. I think that is that's key. I know I feel that personally. I can personally identify with that. So prevention, early detection, and better outcomes. So when trials are representative, that helps those screening guidelines become more accurate too. So African American women and breast cancer, right? Thinking about the breast cancer types that we tend to be diagnosed with versus our white counterparts. Some of those screening tactics have been updated based off of clinical trial outcomes, based off of what we found through clinical trials and actually decreasing the age, right? Like we've gone from 45 to 40. That's a screening guideline change. Seeing that age drop and recognizing that we may need to get screened sooner. That's a screening guideline change. Dosing becomes safer. So making sure that the dose that you're receiving isn't going to create adverse events or ailments instead of creating support, right? Creating solutions for you. Side effects are recognized earlier. And so making sure that we see those side effects earlier, and then prevention strategies that fit real communities. And so, again, inclusive research is the foundation of effective protection and prevention. So I'm gonna ask you, what can you do? Um, what can you do for yourself, for your individual, for your family, for your community, for professionals? I think there are opportunities for us and something that we can take up to take on as a challenge. So for individuals and family, let's make sure to have the conversation, right? Don't let this be the last time you hear the word clinical trial or let the word clinical trial roll off your lips. Go and talk to your family about it today. Get the conversation started. Let's make this commonplace. Let's talk about, and I'm not saying everybody join a clinical trial that may not be for you. What I'm saying is let's have the conversation. Let's not be left out and let's take charge of it. Let's own it for ourselves, for our families, for our community. Let's share credible resources. We know that there's history. We acknowledge the history. We know that there have been some atrocities. Let's talk about it openly. That doesn't mean shy away from what's going on now. We have protections in place. We continue to put protections in place. And we continue to see more and more African American physicians, clinicians, clinical trialists, people like me and Lisa who work adjacent, watching and paying attention and seeing where there are opportunities to partner better with the community. And for if you're a professional, I don't know if we have any physicians on the call, as a clinician or a researcher, make sure that you recruit and refer equitably. Make sure that you push for policy changes that sustain diversity in clinical research. Those people who are in the profession have the opportunity to sometimes sit on Capitol Hill and help push those policies forward that help to support patients that are on clinical trials. And so I will move now to see if we have any discussion. I'd love to know what resonated with you, what will help your community trust clinical research. Where does prevention break down? I want to know. Let's talk about it.
This was great, Alana. You've started a conversation. I don't want it to stop. So, people, if you want to answer any of the questions, I've got some comments for you, but I don't want to be the first always to speak. It's easy for me. Anybody? Belinda, when you were talking about not being offered trial, a trial or something, I have a thought for folks. If you're on a medication and it stops working, or there's side effects, or there are concerns that you have, when you go in, here's an opportunity to ask, are there any clinical trials that I could be enrolled on or in or considered for, since this drug is not working for me, that I, might be a consideration. That's just a thought. It's a way for us to take ownership and
all
ask
the way
a
down
question.
the holdings. And
And so, Lisa, is it typically if you're on a medication that they would ask you to participate?
Unless they're preventive trials, they're
Okay.
not just treatment trials. There are other types of trials.
the health and person,
Yep.
the red, and the red. Lisa,
Yes, Marguerite.
I just wanted to know, why don't we include men in the breast cancer discussions?
Why don't we?
Right. I've not heard anybody say anything about men having breast cancer lately.
Oh, that's what you mean. We should. I don't know the risk of men and breast cancer, but they are at risk.
Mhm.
Right. They're making it sound like it's a woman's disease.
Well, that's something to take under consideration when we talk about it and
Right.
and bring it forward. Even in this conversation, maybe we talk about it differently from the perspective of a man.
Mm-hmm.
Right.
And I
Okay.
think when something is impassioned for me like that, where it's like, how come people don't talk about the impact on men and breast cancer? I feel like you should take that up, Marguerite. You
Yeah.
should take that up. That should be something that you bring into conversations like this, and make sure to bring that acknowledgement, and maybe even, I don't know how savvy you are with technology and things like that, but share that out. I mean, I think that's a fair assessment. We don't talk about it, but men absolutely are at risk for um breast cancer, not at the incident rate that women are. And maybe that's why you get more that conversation more around women than men, but they aren't completely risk-free.
Mm-mm.
That's a
Nope.
very good question, Marguerite, because I had a mammogram just yesterday at Bon Secours St. Mary's. And one of the questions they ask on the form to fill out when you check in was, has your mother, sister, grandmother, aunt, whatever, had breast cancer? They didn't mention men at all. So you're absolutely right. Maybe it has to do with the numbers of men that have breast cancer. I don't know what the statistics are, but they don't even ask that question when you go to have a mammogram. So whether or not a male in your family has had breast cancer.
And that could be due to genetic ties,
Yeah.
Juanita.
Yeah.
Sometimes the cell lines travel with
The
mitochondrial
female.
DNA, which
Mhm.
is maternal DNA. So it
Correct.
travels with the mother. So I'm not an expert on breast cancer. So I can't say whether that's true or not, but I know that could be the reason. Could be.
Thank you.
Yeah. So Marguerite, you've challenged me, so that's important as a part of the conversation, just like you all have with each survey, to submit a topic that is of interest, and Jabs and I take a look at it, and we're building 2026 now. So why aren't men considered in something that are female predominant illnesses, right? So we can talk about it.
Mm-hmm.
Yeah.
I would love to join and hear that conversation.
You're forever on the mailing list, so you can join as often as you desire now. Anybody else in terms of clinical trials and participation there?
I have a question. It's Vera. I have a
Okay.
question. What would be the best place to find clinical studies in our area?
Ooh, I love that question. So there are a couple of websites, and I'll share them with my slides.
Okay.
There are Clinicaltrials.gov is a website that you can find clinical trials. Sometimes it's a little technical, and so there is one that's a little less technical. I'll supply all of the ones that I would use to help support identifying clinical trials that may be something that you want to participate in. You can also look at, especially if you have a large institution near you or a large medical institution, you can go to their website. Sometimes they have their clinical trials posted.
Okay.
Vera, I was going to take liberty if Gwen and or Deborah are still on the call. If for the community, Gwen, if you want to speak to previous VCU or the area, or Deborah, you the same thing as they are nurses, Alana.
Okay.
Nurse practitioner and nurse.
Right. VCU Massey Cancer Center has a website that lists the clinical trials that are available locally. And also and now these are cancer-related clinical trials. And going to the National Cancer Institute, there's a list of clinical trials available there as well. If I recall correctly, they actually list the medical centers that may offer that clinical trial.
Mm-hmm.
They usually do. Yeah.
Mm-hmm.
Yes, and also VCU is doing quite a bit with dementia, Alzheimer's pieces, and they're working with different nonprofit groups that are aligning themselves with churches. So, a number of the things you shared about transportation is being provided for the senior citizens. The people that are doing the trials have actually come to our church, and because other members know of others that are participating, people are loving it, and probably great numbers are participating in that down at VCU because they know, excuse me, other people within the congregation are participating.
Awesome to hear.
Yeah, I was going to say, on this website, you see the Faith Fridays. That's a VCU initiative that is done that
Yes.
includes the church. So
Yes.
churches, so there's that connection and that other opportunity of interaction.
Yes.
Right?
Yes.
Okay. Thank you, Deborah.
You're welcome.
Okay. And Gwen, thank you for that.
Lisa, I was going to also say UVA is fairly close for a lot of people and they don't mind driving, but they also have a cancer center and they are very active in clinical trials as well. So that's also a resource for people.
Yeah, that's a good one. And the actual title for Fridays is Facts and Faith Fridays, because they give you the facts of the health issues they're talking about and couple it so that it's associated with your faith-based affiliation that you're doing it. So it's
and Dr.
really
Nguyen and Dr. Fauci were both at the front of when that started.
Yeah.
During
exactly.
COVID too.
Yep.
Mhm.
Enrichment. Yep, exactly.
And we have a hand up, Lisa Walter.
Okay, go ahead, Walter. Or is it Camille?
I was going to say, hi, everybody. I was going to say that I didn't participate in a clinical trial, but it was more of an observational trial through the Alzheimer's Association. When I was caring for my mother, I had a group of ladies come and just observe my day and just observe how I handled washing dishes, just taking care of general things around the house, even making my bed. They came and just watched me to see if I still did things the way I normally did, or if I had changed the way that I do things because of me watching the progression of my mother's disease. So that was interesting. And there's a write-up about it in the Alzheimer's journals. But so I have participated in that, which was quite an experience.
That's
Wow.
awesome. Yep.
That is awesome.
I think that speaks to the different types of clinical trials there are, right? Like
Yes,
not all of them are related to a drug.
that's right.
Some of them are related to behavioral changes.
Yep.
Exactly.
There are randomized and controlled clinical trials that are focused on health behaviors too.
Again, Lisa,
Yes.
this is Clay.
Hey, Clay.
Hey, good evening, everyone. Just to follow up real quick on someone that mentioned VCU. VCU has an array of clinical trials that they oversee, and they are always looking for minorities to participate in those clinical trials. Um, One of the big ones is substance abuse for, that's the one that I particularly know about, uh, not from personally participating, but that's the one I know about, but they also provide a stipend for those that participate in the clinical trials. And those trials can last anywhere from a few weeks to a few months. And I do have the contact person. And Lisa, if you want me to get that information to you, I can, or to anyone else
Okay,
that
that's
would be
good.
interested.
Yeah, if you email me, I'll make sure that JAPS has it so that we can make it available when we send it out to the
Okay.
group because it's something people were interested in. That'd be great.
Okay, I will email that.
Okay, perfect.
Sure.
And so two additional groups that are similar to the Faith Fridays, the Department of Health here in the Commonwealth of Virginia have something called Partners in Prayer and Prevention, and they do a lot in connection with the Alter, ALTER,
Oh,
Alter Dimension groups. So those are major groups that really work with nonprofits and churches.
oh, that's interesting. Okay. Keep it coming, y'all. We
Yeah.
learn from each other. What better way to pull things together?
Yeah, this is awesome to hear the sharing here. I mean, this is why I do this.
Mm-hmm.
This is it, to get the juices flowing, to get the conversation going, and please don't stop. Please keep talking about it beyond this call and beyond this year. Keep
Yeah,
talking, keep
exactly.
sharing.
If you have a question, raise your hand. I have one thing I want to interject. I think that there is a commitment and a promise that I have to this group going forward, and that is that I want to, upon every call that we have at the end, I want to give you at least one question related to the topic that if you wanted to, since this is about disparities, that you could feel empowered to, at your next visit, ask your physician so that you have something that you may want to talk about. And one of the questions, and we can improve this, everybody on the call, I would say, are there additional tests or assessments you recommend that could provide me more comprehensive understanding of my cholesterol levels or overall cardiovascular health, my diabetes, especially in light of my race and ethnicity? So I think that that's something that's addressing what we're talking about with disparities, etc. I will provide this to JAPS to put in the summary if anybody's interested in a question. So I want us to always have at least one question that we can feel empowered to go to our physicians with going forward from each of these calls. Okay? That's my commitment. If you have others, have at it. I think that's a good thing for us to feel that way. Okay?
Awesome. I love that, Lisa.
Mm-hmm.
That's a good one.
Okay. All right, everybody, 7:34. Alana, it's been a privilege and it's been wonderful to have you. You have other topics, I know you do. We'll have you back at some time if you're interested, if there's something you want to share with us. We'd love to hear from you. And group, any other final questions? Our next call, I think, is the fourth Tuesday in November, right before Thanksgiving. Am I correct, Japs? Yep. It's the 25th. So it will still take place. So if you're standing in your kitchen and cooking, you can listen. So we'll all come together on the 25th. It'll be health related, something fun. And Alana, I think you had somebody related to a dietitian you were thinking of. I want to talk to you about that. So thank you.
Absolutely. I also have a women's CEO academy where I help to support women in their entrepreneurial journeys, and she is a part of that program. I know she would love to do it.
Okay, great. I look forward to that name after the call.
Yeah.
All right, everybody, keep Jamaica in mind. You have a wonderful evening, and thank you for joining.
Thank you, everyone.
Thank you
Have a
all.
you.
for having me.
Wonderful.
Thank you, Alana.
Thank you, Alana. And
All right.
Okay, thank you. Good night.
Thank you. Good night. Good night, everybody.
good night.
Good night or afternoon for you.